Hello, everyone. Welcome to our 2022 Blood and Marrow Transplant Reunion. I'm Dr. Nancy Davidson. I'm a medical oncologist. I'm the former president of the Seattle Cancer Care Alliance and the current executive vice president for clinical affairs at the Fred Hutchinson Cancer Center. I'm also the chief of medical oncology at the University of Washington and the senior vice president for the clinical research division, an honor that I share with my four predecessors, Dr. Donald Thomas, Dr. John Hansen, Dr. Oliver Press, and Dr. Fred Appelbaum. We are so happy that you're able to join us today from across the country. We realize that it's been an especially challenging time for everyone, but even more so for our patients and our survivors. And we're grateful that you've chosen to join us virtually today because we felt we couldn't safely gather indoors for our workshops. Now, some of you have likely heard that we've been really busy at Fred Hutch. On April 1st, the Fred Hutchinson Cancer Research Center merged with the Seattle Cancer Care Alliance to form the Fred Hutchinson Cancer Center, an independent, nonprofit, United Adult Care and Research Center that is clinically integrated with UW Medicine. This restructure brings research and patient care close together and will accelerate research and translate it to our patients, to you, as rapidly as possible. Now, today for our reunion, we have a terrific slate of events. We're going to start by hearing from Dr. Appelbaum, Dr. Fred Appelbaum, Executive Vice President at Fred Hutch, about the progress that we've made over the last 40 years in this important field. We'll then move on to smaller workshops where you'll hear from many of our experts. You'll be able to select which sessions you would like to participate in as we move through the day. And then finally, you're going to hear from Dr. Jeff Hill, who is the Director of Transplant at Fred Hutch and holds the Jose Carreras E. Donald Thomas Endowed Chair for Cancer Research. Now, these workshops have been developed by our Fred Hutch caregivers who have worked tirelessly to perform and support our long-term follow-up in patients. And we really think that they'll be able to provide you with valuable insights. Now, with that introduction, again, I want to welcome you and I want to introduce you to Dr. Fred Appelbaum, who really doesn't need much introduction in this audience. But to remind you, he is currently the Executive Vice President for Fred Hutchinson Cancer Center, former Director of the Clinical Research Division at Fred Hutch, and former head of the Seattle Cancer Care Alliance, my predecessor. And finally, he holds the Metcalf Family Frederick Appelbaum Endowed Chair in Cancer Research. Now, one last thing about Dr. Appelbaum, he's just putting the final touches on a book about bone marrow transplantation. It should be released next spring. And so we're really delighted to have the opportunity to hear directly from Dr. Appelbaum today about the progress that we've made over nearly half a century in the area of blood and marrow transplantation. Fred.
Thank you so much, Nancy. This is just a note that this presentation is being recorded for future use if you're interested. This is the land acknowledgement statement. I've been at the Hutch not as long as the Duwamish people, but close, 45 years since I came here. And I'd like to talk about progress over those 45 years. I know that much of the information that will be of particular interest to you will be how all this applies to your particular situation. And those will be topics that will be discussed in the workshop sessions that follow. Now, when I first came to the Hutch more than 45 years ago, there were so few transplants being performed, they don't even show up on this graph. Remarkably, today, over 100,000 marrow transplants are performed annually worldwide. And there are three areas of progress that account for this growth. The first is the development of donors for everyone in need. The second, which we'll discuss, is the elimination of transplant-related toxicities. And the third is the better eradication of disease. When I came here 45 years ago, the only people that we could perform transplants for were those that had HLA identical siblings or identical twins. And that meant that only about a third of patients from the start would be eligible for a transplant. For 2/3 of our patients, there was nothing that we could offer. In 1978, I was fortunate enough to lead the first study that showed that you could do successful autografts in patients with lymphoma. And then in 1980, John Hansen reported the first successful matched unrelated donor transplant. Today, remarkably, 40 million people worldwide have been HLA typed and have been entered into marrow donor registries, willing to undergo a medical procedure for a complete stranger. I find that just to be remarkable. Other individuals, including Effie Petersdorf and Stephanie Lee, have taught us which donors to best choose among those unrelated donors and the possibility of using mismatched related donors. In the 1990s, Colleen Delaney and Filippo Milano helped lead our program with cord blood transplantation. And suddenly, instead of only having transplants for 30% of patients, we were up to the possibility of doing transplants in over 80% of our patients. And most recently, Rachel Sallet has helped lead our activities in haploidentical transplantation. And so from 45 years ago, where we could only do transplants for a third of the patients in need, now we can find a donor for just about every patient who needs a transplant. The second big area of progress I'd like to talk about is regimen-related toxicities. I've had the privilege of helping to care for quite a few transplant patients over the last 45 years. And over that time, I've had to explain multiple times to patients that they have an otherwise fatal disease and that we have a potential cure, but that the therapy can be extremely dangerous and extremely toxic. And every time I've had to explain that, it is heartbreaking. We've always wanted to do much better. In 1980, the chance of dying as a complication of the transplant, not the disease, the complication of the transplant was about 15%. And for an allogeneic transplant, it was all the way up to 40%. There has been a remarkable reduction in those statistics so that now the chance of dying of an autologous transplant is estimated to be about 1% and an allogeneic transplant about 8%. And there have been three big reasons why we've been able to make transplantation so much safer. And that is the prevention and treatment of infectious diseases, the avoidance of direct organ toxicities, and the reduction in graft versus host disease. When we first started doing transplants, pneumocystis was fatal in about 7 to 8% of our patients, and at least 15% of our patients were dying of cytomegalovirus. With the pioneering work of Joel Myers and Larry Corey, we have now eliminated pneumocystis and CMV almost entirely as causes of death. Candida and Aspergillus have also been big bugaboos of transplantation, but we now have learned how to give prophylactic antifungal medications in studies that have been led by Michael Book. David Fredericks and Steve Pergam have also contributed to this work. Now, it isn't as if infections are no longer a problem. They still can be a problem, but they are remarkably reduced in terms of the risk that they pose to our patients. The second big area in which we made progress in reducing toxicities has been in the avoidance of direct organ toxicities. Over the past several decades, the chance of having severe liver disease has gone down by 10-fold, kidney injury by 7-fold, severe pulmonary complications by 14-fold. And this is in large part due to the work of a talented group of investigators, some of whom are shown here. The transplant procedure is extremely complex. There are huge differences in patients, in their age, their weight, their underlying health and disease, their prior treatment. And during the procedures, the problems, whether they be liver, kidney, or pulmonary, that we can see may be the result of an interaction between the therapies we give and the subsequent development of infections, graft versus host disease, and the myriad of medicines that we use during the transplant procedure. The investigators shown here were able to find their way through this thicket, identifying the likely culprits and developing interventions that have proven to be extremely effective. For example, George McDonald hypothesized that there were likely differences among different people in how they metabolize one of the medicines that we use in our preparative regimens. And he developed a method to alter the dosing based on that information, which proved to be incredibly effective in reducing some of these organ toxicities. David Hockenberry, Sangeeta Hingorani, Guanchin Chen, and Mohammed Saror have also contributed to these studies, among others. The third basic area in which we made progress in reducing regimen-related complications is the reduction in acute and chronic graft versus host disease. Now, obviously, GVHB has been in the past one of the biggest hurdles that we've had to overcome. When I came here, we were restricted to using HLA-matched donors, and we had but one agent, methotrexate, to prevent significant acute and chronic graft versus host disease. But thanks to the work of people like Paul Martin, Joachim Dieg, Masumi Ueda, Marie Bleakley, Marco Macheruk, Paul Carpenter, Jeff Hill, we have developed new methods to help prevent graft versus host disease, and if it develops, to treat it. Now, trying to go through 45 years of progress in 20 minutes, I can't provide very much primary data, but I would just like to show you one study here that Marie Bleakley has been working on, in which she has developed methods to take out the T cells from the stem cell donation that are responsible for causing acute and chronic graft versus host disease, but leaving in the T cells that are important for fighting infections and other post-transplant complications. And with this, this shows you 138 patients that have been treated in this manner, and the risk of developing severe acute graft versus host disease has been reduced to 4%, and the risk of developing even mild to moderate chronic graft versus host disease is down to 6%, a remarkable achievement. Now, this is restricted to patients who are undergoing myeloablative transplants, and we hope to be able to expand these studies to all patients. I also should mention that just over the last year, there have been 4 new drugs approved for the prevention or treatment of graft versus host disease, and people such as Stephanie Hill and others, Stephanie Lee and others have been key in making that happen in the approval of these drugs. Now, almost all of us on this call either have taken care of or have suffered or know someone who has suffered some of the late effects of transplantation. When Don Thomas started transplants, he knew that there would be a price to pay for the administration of high-dose chemotherapy and the treatments that followed. His view, of course, was that cures came first. That's the first step. We had to cure people, and then we'd have to attend to the late effects. But he never shut his eyes to the possibility of these late effects. And so from the very start, we invested a great deal of our effort in researching these. And one of the first pioneers was Gene Sanders to study these late effects. More recently, Scott Baker, Eric Chow, Neil Bott have all been studying these, particularly focusing on pediatric patients. Karen Sorelia has been studying the psychosocial impacts of transplantation, and Mary Flowers, among others, has been key in our studies looking at the sequelae of transplantation, long-term effects, and the sequelae of graft versus host disease. You'll hear more about this research in the workshops that are going to follow directly after my talk. The reason that people undergo transplantation is to eliminate a disease. And so our efforts to make the transplant available and safe are obviously very important, but key is to improve the ability of the transplant to actually eradicate the disease that people are undergoing the procedure for. There are a number of people who have contributed enormously to this. For example, people like Laurie Burrows figured out that what the best regimen would be for patients who have marrow failure syndromes. There wasn't a malignancy to eradicate, but you still had to make sure that the patients could get a sustained graft. And Laurie has figured out the best way to do that with the least possible toxicity. Reiner Storb here, who is second only to Don Thomas as the most important person, making transplantation from the laboratory a clinical reality, saw that much of the anti-leukemic benefit of transplantation was due to its immunologic impact. He developed regimens that rely more on this graft versus leukemia effect than on dose intensity, allowing us to carry out transplants in older patients and those with comorbidities. Bart Scott and Brenda Sandmeyer also contributed mightily to those efforts. A group of us, then asked the question of whether we could make better preparative regimens by targeting our therapies, particularly to sites of disease, using, for example, monoclonal antibodies carrying radioisotopes. This was work that I was involved with, but was really pioneered by the late, great Ollie Press. Other people have joined Ollie, including Johnny Orozco and Brenda Sandmeyer. And I should mention, these pictures I'm showing are only some of the people that were involved, and I've chosen only to show each person's picture once, where they could have contributed to many, many different efforts, but it's just emblematic of the team of people that have been so instrumental in making this research happen. I should also mention that this work on antibody isotopes and antibody drugs has led to the approval now of 11 different antibody drug conjugates. We created the very first one, a drug called Mylotarg, Gentuzumab ozogamicin, but now there are the same kind of philosophy has been applied to a number of different diseases, including Nancy Davidson's favorite, breast cancer, where a very really striking result was just presented at the recent ASCO meeting in patients with metastatic breast cancer. One of the most, if not the most remarkable finding of our transplant studies is that relapse rates are highest in identical twins. They're less in patients who get a transplant from a matched sibling, and least in those who develop acute and chronic graft versus host disease. Thus, there must be genetic differences between siblings that the immune system can sense. And our immune system is just an incredibly sensitive and powerful tool. It's as much a part of us as our brains are. Thus, once we saw that the T cells from the transplant must be seeing the leukemia as foreign and rejecting it, our goal immediately became to identify the population of donor T cells that were seeing and reacting against the tumor, to try to figure out what was it they were seeing, and then could we figure out ways to quickly produce huge numbers of these cells and use them therapeutically. And in fact, we have been doing that. People like Ode Chapuis and Damian Green, along with Dave Maloney, Stan Riddell, and Phil Greenberg, have been focusing their entire careers on harnessing this power of graft versus leukemia. They have identified appropriate targets. They have been able to genetically engineer T cells to react specifically with those targets, and then figure out ways to give these T cells either without a transplant or after a transplant, making sure that they persist, they expand, and they function. I would also point out that these sound like incredibly cutting-edge science, and they really are. But this is what's happening now. We are able to take a donor, find T cells from that donor that are going to react against the tumor, grow those cells, genetically engineer them to make sure they do our bidding, and use them therapeutically. It's really an exciting time. Now, what I've shown you so far are the pictures of many laboratory and clinical scientists. But there are so many other people that contribute to this to provide us with the tools to do our job. Methods to molecularly detect minimal amounts of disease that Derek Stirwall, Jerry Radich, and Min Fang have been leading. Methods to look at our tissues and do the right in-depth pathologic studies, applying new methods such as immunofluorescence that George Sale has pioneered. And then we also have to be able to understand what we're doing from a scientific statistical basis. And we've been blessed to have a really powerful group of statisticians led by Ted Gooley and Barry Storer and others that have contributed. And finally, there are bringing all this to the patient in the clinic, people that have overseen our clinical applications, have standardized our therapies, and created a standard practice, work that Leona Holmberg, among others, has been instrumental in. And what's the result? This shows you the survival of patients undergoing transplant over 3 decades. In the black curve, there's 1,400 patients transplanted in Seattle between 1993 and 1997. And then we compare that to another 1,000 transplanted between 2003 and 2007, and then more than 1,000 transplanted between 2013 and 2017. And you can see this steady progress in curing patients. And I should say, this has been done. These curves are not adjusted. These are the real data, even though our most recent cohort of patients are quite a bit older and have more advanced disease. And even with that higher risk group of patients, our survival curves continue to improve. And when we look at this, we are extremely gratified, but we also know we have a lot to do. But with our newer approaches, developing better preparative regimens, applying methods to prevent graft versus host disease, and to genetically engineer our immune system to specifically fight the tumor, we are extremely optimistic that this trend towards improved outcomes will continue. And it needs to. It's our responsibility to do that. I can't tell you how often I heard Don Thomas, that's the gentleman with the white beard on the left, receiving the Nobel Prize from the King of Sweden, how many times I've heard Don say, we owe it to our patients to do better. And to do better, it takes a village. It takes our lab scientists, it takes clinicians, it takes mid-level providers, it takes nurses, it takes pharmacists, dietitians, schedulers, social workers, clinical staff, stem cell donors, our patients who have so generously volunteered to enter clinical trials and to give us blood specimens and tissue specimens. And it's required our patients' families and their friends to support them during this, these very, very difficult procedures. And of course, we always have to thank our funding agencies and our philanthropic supporters. But with all of our work together, we will do better for our patients. We need to do better for our patients. And I want to thank you very much for being here today and for listening to me talk about 45 years in 20 minutes. Thanks so much.